Y bueno, vamos a continuar también con otro ligero cambio. Vamos a pasar con la presentación del otro colega que está, digamos, en Estados Unidos. Esta presentación va a ser en inglés. Les voy a dar una introducción previa, porque es importante remarcar que lo que se va a hacer ahora es hacer una presentación de un producto que todavía no está disponible en el país y que, digamos, eligieron este evento para hacer el lanzamiento oficial. Va a estar a la brevedad en el mercado argentino, así que le agradezco a Endomedical y a Angionamics por esta posibilidad. Dr. David Wong, are you listening?
Thank you very much for the introduction. I'm just need to screen share.
Yeah.
If you give me the...
Dr. Wong is an interventional cardiologist from the Vital Heart and Pain in Houston, Texas. That's correct?
Yes, sir.
And he will be talking about his experience in the AlphaVac device. I was telling the audience that this device is not yet available in Argentina, but will be soon here. So we are really excited for the information you can provide to us.
Of course. All right. Okay. I'm Dr. David Wong, an interventional cardiologist who practices in Houston, Texas, the United States. I'm a high-volume pulmonary embolus thrombectomy operator, much like many of the other operators who have spoken today. We'll be covering AlphaVac thrombectomy for the treatment of pulmonary embolus. And it's my pleasure to be speaking with you today, and thank you for inviting me. Of course, you have to go through the disclaimer. I'm a consultant of angiodynamics. All right, let's just continue. The prevalence and impact of pulmonary embolism. Let's just start with the definition of prevalence. We all know the pulmonary embolism is the obstruction of the pulmonary arteries by thrombus. In the United States, there are 393,000 cases per year with a population of 334 million, or an incidence of 0.1%. And pulmonary embolus results in 110,000 deaths annually in the United States. Next slide, please. Of course, we are not in the United States currently, and I can only give that example to provide context. Looking at PE, or pulmonary embolus-related mortality, countries in Latin America carry similar rates of mortality in the general population. And pulmonary embolism is an international health concern. Next slide, please. So how do we choose patients that will benefit from pulmonary embolism thrombectomy? It comes down to risk stratification, as all the previous presentations have discussed, and determining who is at significant risk of complication that outweighs the overall small risk of intervention in the right patient, although typically it's normally only small risk with an experienced operator. And we'll discuss the risk stratification categories and the two major scoring systems that are used in my local system. All right, next slide, please. The 2019 ESC guideline splits pulmonary embolism into high, intermediate, and low risk. Hemodynamic instability automatically places someone in high risk. RV dysfunction and abnormal biomarkers such as troponin automatically place someone in at least medium risk. Low risk typically does not need intervention. However, in my practice, if there is a young patient who has a very high thrombus burden, including saddle embolus, I discuss thrombectomy options with that patient, even if they're hemodynamically stable, as they may be compensated due to their young age. All right, next slide, please. You can let it populate through. The PESI index, or the Pulmonary Embolism Severity Index, is a scoring system for determining the risk of PE through several classes from very low to very high. However, it's very cumbersome, and it should not override clinical judgment. All right, next slide, please. You can let it populate. The simplified PESI index is easier, and essentially, if there's even a single point, the patient is at very high risk of decompensation and has an 8.9% risk of death. And this is from a retrospective 5-year data of 3,900 Spanish patients. All right, next slide, please. The overall point of intervention is to reduce complications from pulmonary embolism, which include mortality, inflammation, infectious conditions, long-term RV dysfunction, chronic thromboembolic disease, and chronic thromboembolic pulmonary hypertension. Okay, next slide, please. And why do we perform PE thrombectomy? As the previous presentations have already discussed, there's an improvement in mortality rates, there's an improvement in shock, RV dysfunction, there's improvement in symptoms and exercise capacity, and there's improvement in residual pulmonary vascular obstruction and CTEPH. All right, next slide, please. So let's discuss the AlphaVac system, which is used to provide a percutaneous solution to pulmonary embolism. Next slide. Typically, there's an 8mm access into the femoral vein, either 24 or 22 French. A catheter is advanced under fluoroscopic guidance to the pulmonary arteries. This is a selective catheter, so you can use it to engage thrombus and enter multiple branches. Thrombus is then removed. Angiography and right heart catheterization is typically performed. The device is withdrawn and the site is closed. In the trial, the median case length was less than 40 minutes. This is typically considered a very fast procedure, and the access site typically heals in less than a week. Next slide, please. The data for AlphaVac comes from the APEX trial, which was a safety and efficacy trial in an acute intermediate risk PE. There were 122 subjects at 25 sites. As I mentioned before, procedure time was less than 40 minutes at around 37 minutes. There was a significant reduction in mean 48-hour post-procedural RV-LVO diameter ratio and post-procedural mean arterial pressure. And there was a 35.5% mean reduction clot burden. All right, next slide. Let's just get to the cases. All right, the first case was a 91-year-old woman presenting with syncope and dyspnea. The patient was initially placed on BiPAP support for difficulty oxygenating and work of breathing. The initial blood pressure is 100/60, heart rate is 105, and rest rate was 30. And troponin and lactic acid were both mildly elevated. Next slide, please. All right, could you play the video on the left first? Here is her CT. You will see there's significant PE burden in both the right and left PA. You'll see the right in just a second there. Very large organized thrombus, and then on the right and the left as well. Okay. If you could play the other video, please. It'll start to come in, and you'll see there's a little bit in the apical. The significant thrombus on the right that we saw before. It's fairly chronic in appearance, given some of the smoothness. And then posterior on the left. Okay. All right. We can continue to the next slide. All right. I initially put the system into the right PA and aspirated some thrombus out. Afterwards, I took an angiogram just to see what we had left. You can see we have a large amount of thrombus. So afterwards, using this initial angiogram as a marker, we engaged the thrombus and removed it. All right, next slide. And you can play that as well. And here is the angiogram showing resolution of that thrombus. All right, next slide. Here is our final result in terms of thrombus removed. There was a significant improvement in oxygenation and heart rate. We were able to wean the patient off onto nasal BiPAP. PA pressures did improve somewhat, but were not extremely elevated, which was a blessing. All right, next slide. Case number 2. This is a 66-year-old man with a DVT from 10 years ago, not on anticoagulation at this time. Hypertension, morbid obesity, presenting with syncope at home. He had several episodes of passing out, and his wife could not feel a pulse. She was a nurse, and she performed CPR for 30 seconds at a time at home. He was reported to have a systolic blood pressure in 80s at home, but was 160/90 in the emergency room. He recently had a 3-hour car ride. Patient had a prior possible anaphylaxis contrast allergy, and a VQ scan was performed with high probability in the ER. Patient had an elevated lactic acid of 4.8, high sensitivity troponin of 220, and D-dimer of 71,000. And he did have a lower extremity Doppler showing left femoral and popliteal DVT. Next slide, please. All right, if you could please play the echocardiogram. I've included on the right a guide for people who are not cardiologists or do not often read echocardiograms. The structure on the top, the right ventricle, should not clearly be that size. I think it's probably about 3 times what you expect, and it's crushing the left ventricle, which explains his episodes of syncope at home and his decompensation. Okay. All right, let's go on to the next slide. If you could play the video on the left, please. All right, you can see in a second his thrombus on the right side going up to the truncus and then going down into the left posterior. Okay, and if you could play the other video, please. Again, thrombus bilaterally in those locations we discussed, and you can see the RV is quite large on the CT as well. Okay, we can continue and go on to the next slide, please. All right. I performed this procedure without any contrast due to his contrast allergy. It was performed on BiPAP as well. Did not require intubation. The patient did have an improvement in his PA pressures from a mean of 39 to down to 32. There was possibly some chronic component, and he did go from BiPAP to nasal cannula at the end of the case. All right. Next slide. Here again is his echocardiogram prior to the procedure, and then echocardiogram performed 2 days later, if you could play the other video. Although it did improve further later, and we did repeat the echocardiogram at 2-month mark, there was a significant improvement already at 2 days. All right. Next slide, please. All right. The last case is a young man. We're slowly decreasing the ages with each case. This is a 30-year-old man found to have shortness of breath and lower extremity pain for 2 weeks, found to have DVT and saddle PE. He denies any prior past medical history, no family history of VTE, and no recent immobility. Next slide, please. All right. I believe this is a still, but yes, there's a saddle PE seen there, and there's also a small pulmonary infarct on the right lower lateral basal segment. Next slide, please. Also another static view, left femoral popliteal DVT. All right, continue. Next slide, please. Again, another successful result. Remove the saddle thrombus. Patient did improve oxygenation overall, around 200 cc's blood loss. We returned 175 cc's, which is off-label, and about a 145-minute total time, including sedation, and so about 20 minutes device time. All right. Next slide. We also removed his DVT with the device as well. All right. Next slide. That's the end of the cases. Does anyone have any questions?
Did you perform the DVT procedure in the same stage, or it was?
Look, we performed it the following day, just to allow the patient some time to rest. We also often, if we perform the procedure from up and over using the contralateral leg, then sometimes we will do it as part of the same procedure. But if we do from a popliteal access, we'll stage the patient so they're more comfortable.
So the same device for both DVT and PE?
You can use the same device for DVT and PE, and depending on how the patient is looking, if you would like to do it in the same procedure by going up and over and using the same femoral access, it's a possibility.
¿Hay alguna pregunta de los casos clínicos que quieran hacer?
Yes. Did the patients need some transfusion? What about the anemia and the red blood cell count?
The patients did not need transfusion. The 80-year-old's hemoglobin was about 9. Overall estimated blood loss for these patients is around 200 cc's, can be up to 400, depending on how aggressive you want to be with the drawing of blood. However, we do have a off-label blood return system where I return about 90% of the blood that's taken. So in the vast majority of cases, unless the patient already has existing anemia, we do not really require blood transfusion.
The procedure is standardized. For example, we have some experience with FlowTrigger, and you have to go to the right, lower lobe first, then up, and then to the left. It's the same in here, or you just go where the thrombosis?
So it's flexible. The way that I practice the procedure, typically I go straight to the right just because I feel the right is an easier target for any thrombectomy system because of the lack of branching. And you really only have 2 things to worry about on the right, which is the truncus and then the main branch. And so I'll perform aspiration on the right. After about 5 minutes, I'll take a picture, flip over to the left, which takes about 10 seconds, and then I'll work my way through the branches to the left, posterior, medial, and apical.
And the aspirations are not over the wire. You remove the wire for aspiration.
Yes. For this device, you can work completely without a wire, which is actually very helpful. It may take some getting used to if you're not familiar with it or if you're not comfortable with it. However, it's fairly easy. There is a fin that allows you to manipulate the catheter, and you can advance the catheter fairly deep into the truncus or into the distal posterior. It's an atraumatic funnel, and so you're able to go fairly deep. The benefit of this funnel also is that you're able to scrape the more distal vessels and scrape out clot that is wall adherent. Of course, nothing will ever remove truly chronic thrombus that has been there for a long period of time, months, but you can get subacute thrombus out this way that may not come out with other means.
Great. ¿Alguna otra pregunta del público? So there are no further questions from the audience. I would like to thank you, Dr. Wong, for your time and for your presentation. We're really looking forward for this device entering our market soon. So thank you very much.
All right. Thank you very much as well. You take care.